Welcome back, guys. So, in this module, what we are going to see is we are going to see about chronic inflammation. We are done with acute inflammation. We are done with the diseases of acute inflammation. The next thing is going to be chronic inflammation. We already know what is the hallmark of chronic inflammation and what cells are involved in chronic inflammation. Now, we are just going to see how the characteristic granuloma, which we have, it's perplexing us for long, right? We're going to see how it forms, how it looks, by looking at a granuloma, can I say, okay, this guy is the culprit who caused it? Clues for diagnosis. And the mechanisms, the interleukins, the cytokines involved behind the formation of the thing. Okay? And giant cells, most importantly, Langhans giant cells. Right? We're going to see all about it, right? So smile on your face. Let's start. So we're going to see about chronic inflammation. The first and the foremost question is, when does it happen? So when does it happen? When an acute inflammation fails, chronic inflammation happens, right? We saw in one of the diseases, chronic granulomatous disease. When due to any cause, not just to disease, when acute inflammation fails. When acute inflammation fails, I'm going to have chronic inflammation. Okay? Or when the organism or the stimulus, I'm not just writing organism, the stimulus is persistent. It could be an irritant, it could be a cold, right? It's persistent. When the stimulus is persistent, I may have a chronic inflammation. And sometimes autoimmune conditions. We may have an autoimmunity where obviously stimulus is persistent till the person lives, right? There also we are going to have chronic inflammation. These are places we are going to see chronic inflammation. And as we know that the cell of chronic inflammation is macrophage, not a lymphocyte. The cell of chronic inflammation, like acute we had neutrophils, the cell of chronic inflammation is going to be macrophage. Monocyte macrophage system both means one and the same. Fine, monocyte in blood, macrophage in tissue. Fine. That's the cell of chronic inflammation. So when do I call lymphocyte? As we already read, lymphocyte means I'm going to have two things in my mind: virus and autoimmune disorder, right? Mostly, when in these two conditions, if their chronic etiology is either virus related or an autoimmune disease, yes, I will have lymphocyte predominance, lymphoplasmacytic predominance, right? That will be there in these two conditions. Fine. So we are just done with the cell of inflammation. But this macrophage, no, it has different names in different organs. And it's like a thief who eats. Goes in different place, changes its name and disguises. You just see the names of macrophage, right? So macrophage, we'll start with the ones you know already. In liver, yeah, perfect, they are called as Kupffer cells. Splenic macrophage, in spleen, they are called as littoral cells. They are same macrophage, same function, different terminology. CNS, microglia is a macrophage. They do the function of the macrophage. Kidney, we have mesangial cells. They do the function of the macrophage. Right, the mesangial cells. In lung, I'm just going to call it macrophage only, but a tiny different name because of its function. They're going to absorb all the things which we inhale, so they're also called as dust cells. It's just fancy terminology, nothing much. Synovial fluid or synovial lining or in joint space. What are the macrophage in joint space? Joint space has only one cell. Then what? Synovial cell, synoviocytes. Okay. Synovial cells, so your synovial sites are the macrophage in my joint space. So I'm going to have different names, but the same function, same everything is going to be same. We are just going to have the macrophage. Just names. So I said that macrophage is going to be involved in chronic inflammation. A monocyte will come to the tissue, will become a macrophage. Monocyte doesn't live long, but macrophage can live for years together. Macrophage doesn't live as such as macrophage, it becomes activated. So I'm going to have two important cells in, not just macrophage, it has one more phase, an activated macrophage. So I have two things, macrophage and an activated macrophage. Who causes the activation? And what are the types of activations? What next we are going to see. We're just, as usually, having the raw materials ready. Once the raw materials are ready, we'll put in all our requirements and we'll build a beautiful building of pathology, right? So we'll get our raw materials ready. So what is an activated macrophage means? Who activates it and what are their function? So normal macrophage becomes an activated macrophage with the help of few interleukins. And there are two types of activation: M1 or classical activation, M2 or alternate activation, right? So now normal macrophage becomes an activated macrophage in two different ways. I have M1 or classically activated macrophage and M2 or an alternatively activated macrophage. Same like your classical complement system and alternate complement system, just terms, right? So in a normal macrophage has few interleukins, it becomes M1 activated. So what are those interleukins? A normal macrophage will become M1 activated macrophage if they have microbial products. If they are microbe products, they become activated macrophage to the M1 lineage, like your toll-like receptors, the ligands of toll-like receptors, and interferon gamma. This guy is important. Remember this guy? This guy is very important for me. With the help of interferon gamma for an MCQ as well, a normal macrophage becomes an M1 activated macrophage. So what does this M1 activated macrophage do? It's an activated macrophage. Its function is different. Normal macrophage knows only one: eating, like us. Activated macrophage. You're eating too much. You get activated. What will you do? Secrete. Same thing this guy does. The function of both the activated macrophage is secretion. Again, an MCQ point. It doesn't phagocytose. It secretes. What do they secrete? More interleukins. The only goal is to make sure the inflammation goes on and on and on. Right? So they do secrete. What do they secrete is they secrete more interleukins and more reactive oxygen species. So these are the things which are secreted by the M1 activated macrophage. They secrete reactive oxygen species, nitric oxide. This is going to help in killing the microbe. It kills the microbes, which causes the activation, first thing. It also secretes interleukin 1, interleukin 12, and few other chemokines, which is going to make sure the inflammation stays for long. It's inflammatory. So in other words, M1 activated macrophage is going to help in the chronic inflammation process. M2 is not. M2 is a totally different role. So whatever we are going to see next is because of this M1 activated macrophage. That's the reason I said this interferon is very important for me. Everything is based on the M1 activated macrophage only. So how does macrophage get activated to M2 type, and what is the exact function of this M2 activated macrophage, right? So an M2 or an alternate activation happens when you're going to have interleukin 13 and interleukin 4. When any of the molecules secretes interleukin 4 and 13, a macrophage will become an alternatively activated macrophage, right? So it becomes an alternately activated macrophage. Function is the same, secretion only. It also secretes. But they don't secrete the same what M1 secretes. Different secretion, different function, right? So what do they secrete is, they're going to secrete growth factors. They secrete growth factors and TGF beta. This is going to help in wound healing process. It's going to help in wound healing process. Okay, tissue fibrosis, because TGF beta help is very important. Tissue fibrosis, we'll be seeing them in healing chapter. Okay, and also it secretes interleukin 10 and few anti-inflammatory cytokines. So the main role, now I hope it's clear. I'm just going to zoom out. So look at this. Look at this. So this is what happens. We saw acute inflammation. I'm going to take you back, drag you back to the acute inflammation chapter. In acute inflammation, we saw rolling, diabetes, blah, 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 blah. Neutrophil came, phagocytose destroyed it. And I said that at the end of destruction, these neutrophils should be removed. Who will remove? Macrophage. Macrophage comes in, engulfs it and removes it. First way. Once it is removed, it becomes activated into, if everything is clear, it becomes activated to M2 subtype, makes anti-inflammation and wound healing. Clear? Comes again, macrophage comes here. It's seeing that this neutrophil is struggling, not able to do anything. So it comes here, gets activated to M1 subtype, makes the acute inflammation chronic inflammation. Just going to compound it and make it chronic inflammation. Macrophage knows their role perfectly. Either help in wound healing and stop the inflammation, or aggravate the inflammation and make it chronic. Now we are going to see about chronic inflammation. That part we'll see later. M2 activated macrophage also has one more important function in neoplasia. We'll read them when we come to the neoplasia chapter. Fine. Now let's go on to the chronic inflammation alone. We're just going to take a chronic inflammation, and the prototype what we're going to discuss with chronic inflammation is going to be a ever amazing tuberculosis. Ever amazing tuberculosis. That's what we want to see. Fine. We're going to see about tuberculosis. That's all. So I'm going to have a cell, which is my macrophage, and my macrophage is going to ingest the TB organism. Fine. Let's have this is a macrophage. What happens is macrophage is going to try to eat my tuberculous organism, the TB bacilli. Fine. I'm writing macrophage plus tuberculosis bacilli. TB bacilli is so damn amazing. It goes into the macrophage and says, do whatever you want. I will divide inside the macrophage. Thug life. Amazing. Can't do anything. Macrophage can just shit, that's all. TB divides inside macrophages. Divides in them. They are amazing. So now this macrophage is like, what will I do? I'm having something which is going to divide inside me. Okay? So what macrophage is, okay, I'm going to call help. That's in chronic inflammation. So what this is going to do is, this macrophage is actually an antigen presenting cell as well, right? Every macrophage is an antigen presenting cell. So what it does is, it's going to process the TB antigen and presents it. And going to present to whom? Macrophage has type 2 MHC molecule, right? It has MHC2. It presents the antigen to your cell which has CD4. Okay, it has CD4. A CD4 T cell. It's going to present to a CD4 T cell. Okay. So once it presents to a CD4 T cell, if you remember your microbiology, CD4 can get activated with TH1, TH2 and TH17 pathway, right? So I'm going to present my tuberculous antigen to my CD4 T cell. So this CD4 T cell is going to get activated. It's going to get activated via TH helper 1 pathway. Okay. So this TH helper 1 pathway is again going to secrete one very important molecule for me. This TH1 pathway, if you remember microbiology, everything is interlinked. It's going to secrete interferon gamma. It's going to secrete interferon gamma. Does it ring a bell? Yes. With the help of interferon gamma and obviously my microbial product, this macrophage is going to become an activated M1 activated macrophage. Okay, it's going to become an M1 activated macrophage. So this M1 activated macrophage is going to secrete more interleukins, right? We saw interleukin 1 and 2 and few other cytokines. The M1 activated macrophage, what it does is, it's going to secrete, we know its function, it's going to secrete interleukin 1, interleukin 12. Okay, so what interleukin 12 is going to do is, interleukin 12 is going to go and act on my CD4 cell to produce more interferon to convert more macrophage to activated macrophage. Like a vicious cycle. It's going to help. Each other is going to help and produce more and more activated macrophage. Produce more and more activated macrophage. Fine. Then what happens? Interleukin 1. Interleukin 1 is going to attract more lymphocytes. Okay, it attracts more lymphocytes. So these are the players now. We know the players. You are going to draw how it's going to look. You are going to draw how it's going to look. You heard me correct. Listen carefully to me. Put your pens down. We'll discuss. We had a macrophage. We know that how a macrophage looks. We saw the initial chapter how a macrophage looks. A clear cell, a foam cell. Now this macrophage ate everything, not able to do anything, became an activated macrophage. Function of activated macrophage is not phagocytosis, secretion. They have to secrete. When they have to secrete, there are a few things should happen to me. One, my nucleus should change in configuration, right? It should become euchromatin. It has to change a little bit. Second, I'm going to secrete interleukins, which are nothing but proteins. So will the cytoplasm color change? Yes. to what color? Pink color. Because pink is equal to proteins, right? So my cytoplasm color is going to change, my nucleus configuration is going to change, and my activated macrophage looks totally different. I know you have something in mind. I'm just going to draw it, see if it matches. Okay, I want you to imagine. I'm just going to draw whatever we saw. My nucleus changes in shape, becomes a bit elongated. My cytoplasm becomes a pink color cytoplasm. This is how the cell looks. When I make the cell stand straight, I'm just going to derive to the name of the cell, nothing else. And I'm going to make the cell stand straight, right? An elongated nuclei and a pink cytoplasm. Does it look like a columnar epithelium by any chance? Yeah, a little bit, right? Looks like an epithelial cell. Name the cell. Epithelioid macrophages. Medicine and pathology is wonderful. You're going to, I said, right, you're going to write pathology. You will write pathology. So it's going to be epithelioid macrophages. One or plenty. Will be plenty because vicious cycle. More and more and more interferon gamma. And not just one. I'm going to have plenty of epithelioid macrophages. Okay? I'm going to have plenty of epithelioid macrophages. Or they are called as histiocytes. Both mean the same. So I'm going to name this cell. We're going to name the cell. The activated macrophage got one more term. It looked like an epithelial cell, so an epithelioid histiocyte. Histiocyte is macrophage. Okay, histiocyte. Fine. It's histio. Okay. How does they look? An elongated nuclei. The person who first saw, for him, slipper came to mind. It looked like this. It's going to look like this with the central constriction. I would have called it dumbbell. I don't know from whom he got a hit. He called it slipper shaped nuclei. Fine, let it be. Whatever it is. Okay. Slipper shaped nuclei. And we'll have an elongated cell with a pink cytoplasm. This is how it looks. And multiple are there. Now let's come. So all these guys are fighting against one single person, tuberculosis. Not able to kill them till now. So I have this finding. I'm having multiple epithelioid cells. In your college, you must have, when you joined your college, when you have a unit in your postings, there'll be 10 people. Within the 10 people, you'll have two groups. And groupism, worst character ever. You do groupism because this guy also does groupism. He has similar properties, similar function. So they join together. So they join together, what's going to happen is, I'll have something like this. When they join together, the cytoplasm color will be pink in color, obviously, because everything is pink in color. And I have nucleus, multiple nuclei. When I have multiple nuclei, I'm going to call the guy giant cell. So giant cell is nothing but all these epithelioid macrophages, few of them fuse to form giant cell. So giant cell is nothing but epithelioid macrophages fused together. Fine, we got them. Even this guy is not able to destroy the tuberculosis. So you got a guy who is your enemy, you are not able to kill. What will you do? Phone the friend, macha wah. Right, we'll kill him. We'll hit him. Same thing my body does. Phone a friend, phones lymphocyte. With the help of interleukin. With the help of interleukin, calls lymphocytes. Come on. Let's kill this guy. You guys know how lymphocyte looks, right? You guys know. How do they look? In biopsy. Small round blue cell. Perfect. So what's going to happen here is, I'm going to have lots of small round blue cells here. Okay, lots of small round blue cells surrounding this epithelioid macrophages. Lots of them. It will be all around. You just drew the entire granuloma. This is how granuloma looks. Why do you want to learn medicine when you can create medicine, right? Why do you want a textbook? You are the textbook. Your mind is a textbook. Your imagination is a much bigger textbook than anything else. I'll keep telling this 1,000 times because I believe in it. You can do it. You drew a granuloma from scratch. Just knowing basics. This is a granuloma. The entire structure is in granuloma. See, when you draw a granuloma, when I give an image, you can easily correlate. If you just see the image, you will not be able to correlate. We know granuloma. Just put your pens down, again listen to me. A macrophage came, ate my tuberculosis, not able to destroy it, became an activated macrophage by presenting the antigen presenting cell, to my CD4, which gave me interferon gamma. Became activated, secreted interleukin 12 more, stimulated my T helper cells again, more interferon, more activated macrophage. All of them grew, formed the giant cell. One more person, what this activated macrophage secreted is interleukin 1, which got the lymphocytes. If these guys are powerful, they'll put the tuberculosis in the center and kill them. Caseous necrosis in the center. Perfect granuloma. That's how a perfect granuloma looks. What do you want to learn when you can create something beautiful? Look at this guy. Look at that guy. Everything what you read will be there. Look at the surrounding corners. Small round blue cells, lymphocytes. Right? Look at the center. What color? Pink or blue? Pink. Because they are epithelioid histiocytes. More pink cytoplasm. All these guys. I'm just drawing one guy alone out for you. Standing it out. All of them are your epithelioid histiocytes or your activated macrophages. Or an epithelioid cells. There's one big guy, right? Who is this? Giant cell. Granuloma. Is it simple? It's very simple, right? We just confuse ourselves. Medicine is very simple. We read something and this is how your question comes. Name the type of inflammation seen in the picture. You see a granuloma, you have to laugh at the question. You're going to laugh at the examiner. What question you're asking? Much more beautiful than you are. Much more powerful than you are. Right? Just a second. You know where it went. Sorry. Okay, yeah, here. Came back. That's how granuloma looks. Fine, that's how entire granuloma looks. And that's not enough. We have to step up. These are my basics. You have to step up. To see, when I'm looking at a granuloma, I want to try to diagnose few different things. I want an etiology, not a finding. I want an etiology, right? For that, we're going to divide granulomas into different types and try to find out the etiology. Fine? First, we'll divide them based on giant cells. Based on giant cells, we are going to divide granulomas. Okay? First, when you see a giant cell called as Langerhans giant cell, I'm sure you know where I'm leading to. Langerhans giant cell is, you have a nucleus in the form of a U or a horseshoe. Giant cells are named based on the appearance of nuclei, that's all. A horseshoe-shaped cell. Okay? Horseshoe-shaped cell or an U-shaped nuclei, not cell, horseshoe-shaped nuclear arrangement. This is going to be seen in tuberculosis. Langerhans, not Langerhans, right? It's Langerhans. Second, when I have something, when the nuclear arrangement is in the form of a circle, it's forming a tiny little circle, complete circle. I'm going to call this giant cell as two-tone giant cell. Nice name, right? Two-tone giant cell. Two-tone giant cell, the nucleus is of circular arrangement. When the nucleus is forming a circle, I'm going to call it two-tone. Where do you see it? You're going to see it in xanthoma. When I see such giant cell, I'm going to think of a xanthoma. Xanthoma is where what you see in your hypercholesterolemias and all those conditions, right? I'm going to think of a xanthoma. Third, when I have a giant cell, I'm just looking, I don't have any specific arrangement. Random, very randomly located. Haphazard arrangement of nuclei. No particular pattern. I'm going to think of a foreign body giant cell. A foreign body giant cell will have no pattern of arrangement. Fine? Foreign body giant cell or a foreign body granuloma. There will be no particular pattern and haphazard arrangement of nuclei. So what is a foreign body giant cell? When you leave a suture back, after suturing, you remove the suture, you will not have the same excitement when you put a suture. Same excitement will not be there when you remove a suture. Cut and throw, cut and throw. That should not be there. You should have the same interest when you remove the suture. Because if you leave a little bit of silk inside my body, non-absorbable, my macrophage tries to come to eat. Can they eat? They can't. They become activated, becomes a granuloma. Suture granuloma, very common. Suture granuloma, you'll have foreign body type of giant cell, right? Examples of foreign body granuloma, suture granuloma. There's another name for this. Suture material is in foreign body. Will the refractive index of a foreign body and a human cell be the same? No. So I'm going to also call this refractile granuloma. Just a different term, that's all. We're going to call them refractile granuloma. Right? Suture granuloma or refractile granuloma. There are three variants of granuloma based on the appearance of giant cell. Fine. Then we'll go to based on the appearance of necrosis, whether it's necrotizing or non-necrotizing. As I said, caseous is not the correct term, but fine, caseating, non-caseating. Though it's not the correct term, I'm just going with the dictum because most of the textbooks say that caseating granuloma and you're going to have non-caseating or non-necrotizing granuloma. Fine. I prefer non-necrotizing, but yeah, it's fine. Okay. Caseating granuloma. One guy you will never forget, tuberculosis. I'm sure other two guys also you will not forget, histoplasmosis and coccidiomycosis. We saw them in caseous necrosis, same three guys. I'll add one more thing, I'll add so. Mycobacterium, not only tuberculosis, lepra also can cause granuloma. Lepra can cause caseating granuloma, especially and only if they are around the nerve. So I'm just going to write as pure neuritic leprosy. Not anywhere. When it's pure neuritic leprosy, they do form necrotizing granuloma, not any other types of necrosis. Only pure neuritic leprosy. Fine. Non-caseating. I'm sure your brain will be shouting sarcoidosis. First and foremost is tuberculosis. Write this in big letter. If you want, take a photo of this and paste it in your entire room. I never want you to forget this. Granuloma, necrotizing or non-necrotizing, has to be tuberculosis first, always. It's a rule. It can never be anything else. This came in the last year NEET exam. Many of the students wrote it wrong. Just because you're diagnosing sarcoidosis, you're not a great doctor. You have to diagnose tuberculosis. That makes you the great doctor. I will tell why non-necrotizing. That's your question, right? I'll answer everything. Don't worry. I said you and me discussed how a granuloma formed, right? All the guys came and put the TB in the center and killed him. If I'm able to kill him, I will have necrotizing granuloma. If I'm not able to kill him, if my immunity is less, not so powerful, not able to kill him, no necrosis, that's all. So TB, whether it's necrotizing or non-necrotizing, based on your immune system of an individual. Powerful immune system, kill the TB, have necrosis in the center. Not so powerful, TB will not be dead, no necrosis. That's why TB has both. Always first choice should be tuberculosis, never forget. If you make a mistake, I'll definitely come to the exam hall and kick you. And there are few things which I'm very, very particular about. Never make a mistake. Then sarcoid. There are a few other conditions as well. I'm not saying not sarcoid. Sarcoidosis for sure. Then sarcoid. But sarcoidosis should be having biochemical, radiological, and pathological finding. Sarcoidosis is a diagnosis of exclusion. If nothing is nothing fits in, and all the thing favors sarcoidosis, only then sarcoidosis. Otherwise, no. Right? Diagnosis of exclusion. Hodgkin's lymphoma. Hodgkin's lymphoma also will have granuloma. Hodgkin's lymphoma will have granulomas. Right? Non-necrotizing. RSL plus granulomas. Right? That's about necrotizing and non-necrotizing granuloma. Sarcoid granuloma is a bit special. You have to read about sarcoid granuloma, right? Read about sarcoid granuloma. So how a sarcoid granuloma is special from a tuberculous granuloma is what we are going to see. Maybe in corner, or maybe we'll imagine a tuberculous granuloma. You must have read in your surgery that TB granuloma forms coalescing granulomas. All the small granulomas coalesce and the entire lymph node will be involved. Not only the lymph node, the periadenitis also will be there. That makes it matted. Entire thing gone. Sarcoid is not like that. Sarcoid granulomas are discrete. That's my first finding. They are discrete granulomas. Okay, are completely discrete granulomas. Which means they are going to be individual, right? They are going to be discrete granulomas. They're just individual granulomas. Maybe I'll give it a space here, draw on the side. Individual granulomas, like this. Everything will have epithelioid cells, giant cells, and all, but individual. Why they are individual is when we look at it deep, when you look at it carefully, we know that every granuloma has fibrosis surrounding it, well walled off. Every granuloma has perigranuloma fibrosis. Fine. Perigranuloma fibrosis. That's also classic for sarcoidosis. I'm just drawing a perigranuloma fibrosis, a pink color surrounding the granuloma. That's the reason the granulomas are discrete, they're separate. Okay? Perigranuloma fibrosis. They will not coalesce like your tuberculosis. And one more important thing, they'll be discrete. Perigranuloma fibrosis, yes, obviously it is non-caseating or non-necrotizing to be specific. Okay. The most important thing is when we saw granuloma, we had epithelioid cells, we had giant cells, we had lymphocytes. Here, lymphocytes will be characteristically absent. There will be no lymphocytes. No lymphocyte cuffing to be specific. There will be no lymphocyte cuffing seen in a sarcoid granuloma. I won't have them surrounding the granuloma. Because of this, they have a fancy term. I'm sure you'll never forget this because of your dirty mind. They're also called as naked granuloma. Okay? It's also called as naked granuloma. Apart from these, I have few named findings. Like Langhans-Giant cell in tuberculosis, I have few named findings in sarcoidosis. Do remember them as well. There's something called as Schaumann bodies. These three findings are not specific for sarcoidosis. They can be seen in multiple conditions, but also seen in sarcoidosis. That's all, fine. Schaumann bodies, they are calcium inclusions in giant cells. They are like concretions of calcium inside the giant cells. Basophilic, same like a Samoma body, but inside a giant cell. Fine. Have something called as an astroid body. Astroid, as the name says, is going to be like a star. It's going to be like a star. That's all. I'll have an giant cell. These are also inside a giant cell. Let's make it pink color. Okay, let's give the nuclei as well. So how an asteroid body will look is, it will have an empty space. That empty space have kind of a star. That's how an asteroid body looks. They are star-shaped inclusions. They are eosinophilic. They'll be pink in color. I drew it pink color. Star-shaped structure. Okay. They are also protein. They have just a shape is different. That's all. Again, this is not specific for sarcoidosis. I can see them in quite a few conditions described in sarcoidosis. Fine. And we also have something called as the third one may not be required at all. Just remember it since we are dealing this. Called as Hamasaki-Weissenberg bodies. Okay. Just I'll name it. That's all enough. Hamasaki-Weissenberg bodies. See, these terminologies are very commonly used by pulmonary pathologists. We do have pulmonary specialty for pathology as well. They see lots of cases. Yes, they may be able to identify. But as of now, for us, non-caseating, discrete granulomas and perigranular fibrosis, no lymphocyte, think of sarcoid. Provided there's a history of hilar lymphadenopathy, CD4 excess, X-ray sensitive of sarcoid, and also your acetylcholinesterase level elevated. Everything should be there. Only then sarcoidosis. Otherwise, never sarcoidosis. Right? That's the difference between sarcoid granuloma and a TV granuloma. We are done with that as well. Obviously, we need few special hints, right? Without a special touch, medicine never ends. The special variants of granuloma is where most of the questions come. There are few special variants of granuloma. What are they and how do they look? The first, stellate granuloma. We have something called a stellate granuloma. Okay? Stellate means star-shaped. It will not be exactly star-shaped. It will be irregular, that's all. There's a granuloma which are neutrophils also. They are actually microabscesses, right? These are irregular granulomas. If you want to imagine, yes, like a star, you'll have neutrophils, lots of neutrophils. Okay, you'll have neutrophils in the granuloma. They'll be irregular like a star. And it is seen in a disease caused by Bartonella henselae. Perfect. Cat scratch disease. You want to see them in cat scratch disease. like Barton-Lange. Okay, that's a stellate granuloma. I'll show you the image. I'll put them in the image bank. It's there already in the image bank. Fine. Second one, I'm going to call something as a microgranuloma. So when do I call something microgranulomas? When there are less than 25 epithelioid cells. The number is important. Less. Sometimes if you want you can count, but less. The most important thing is there should be no giant cells. There will be no giant cells at all. Just in other words, epithelioid cell clusters here and there. It's very common and is diagnostic of a condition called as Toxoplasma lymphadenitis. When Toxoplasma lymphadenitis is there, this finding is very, very important. Okay? Toxoplasma lymphadenitis, microgranuloma is a very important finding. Fine? That's the second. Third, just variants of granuloma. Donut-shaped granuloma. Okay? Donut-shaped granuloma. Just the shape looks like a donut. I must have called it a vada-shaped granuloma. A granuloma of the central hole. Donut-shaped granuloma is especially seen in liver, in Q fever. Again, I'll put the image in the image bank. It looks like a donut. The central hole looks like a donut, right? We should have named it first. Those ugly American English people have named it first and call it donut. Okay? That's the few different types of granulomas. Maybe as an MCQ, right? So that marks the end of the chronic inflammation. We'll see a few questions related to chronic inflammation, then we'll call it a day. Fine? Because we have read about lots of granulomas. Look at the images as well, right? Okay. First question. What is giant cell called? Look at the nuclei. Arrangement is circular. I have a circular element here, here. So it's a two-tone giant cell. Perfect, right? I'll show you next giant cell. You're going to name it. What is giant cell? Name the giant cell. Doesn't look like Langhans, doesn't look like two-tone, doesn't look like foreign body. I have only two nuclei. Perfect, that's your RS cell. I want you to remember that when we come to Hodgkin's, we will extrapolate. RS cell is a tumor giant cell, which means RS cell originates or has little bit of attachment to macrophages. I want you to remember this. We'll definitely see it when we come to RS cells. Fine. We will extrapolate. You are going to extrapolate. This we saw a perfect granuloma, right? See here, I'm just going to mark numbers where I'm going to see granuloma. I'm just marking wherever I see granuloma. Multiple, correct? But when you look at this, each and every granuloma is separated by central fibrosis. Discrete, non-necrotizing fibrosis perigranular. This is how sarcoid granuloma looks. This is how sarcoid granuloma looks. If you carefully observe, I'm sure you must have got one doubt. This guy said you won't have lymphocytes, right? If you carefully observe, you must be wondering, what are these cells? In between, what are these cells? He only said that there will be no lymphocytes, but there are lymphocytes. These are not granuloma lymphocytes. This sarcoidosis has occurred in a lymph node. So can lymph node have lymphocytes? Yes. They are not because of the disease process, they are because of the organ. Right? So they are not because of the disease process, they are because of the organ. So those lymphocytes are allowed. But I don't see any lymphocytes here. Maybe this is close to the capsule. There's no lymphocyte in the entire half. Close to the capsule, no lymphocyte. So disease process has no lymphocyte. Those are the normal lymph nodes lymphocyte. So don't get confused with that, right? This is how sarcoid granuloma looks. Fine? Okay, just one more question. A 41-year-old woman complains of excessive menstrual bleeding, pelvic pain for 4 months, intrauterine contraception is there, endometrial biopsy shows plasma cells. They have given plasma cells. Yeah, it looks like a plasma cell. Eccentric, pink color, even this has perinuclear off, right? So which of the following is the type of inflammation? Chronic. Why didn't I write granulation? Granulomatous inflammation is, I'm not seeing granuloma. I'm seeing lymphocyte plasma cells. I'm just going to call it chronic. Unless and until I see granuloma, unless and until you see granuloma, you cannot call it granulomatous inflammation, period. Right? It's just a chronic inflammation. I just put a question so that you don't get confused, that's all. Okay? With that, we come to the end of chronic inflammation. So what we have done till now, what we have achieved till now is Inflammatory cells, you know how it looks. Acute inflammation, the steps. Diseases of acute inflammation. Now we are doing chronic inflammation. Next chapter we'll be doing about the acute phase reactants and also about the systemic patterns of inflammation. Okay, go grab a cup of coffee, our routine, and then switch on to the next video. Till then, bye bye from Dr. Ranjit.